So thank you again for joining us. Now I will turn over the presentation to Kathleen MacNeill with the Diabetes and Health Education Department here at Florida Healthcare Plans. Thank you for joining us, Kathleen.
Thank you. Hi, everyone. I hope you're going to be informed and learn something from this. This is Diabetes 101, so it's things that a lot of people already know, but maybe you'll hear something or take some little pearls of wisdom away from today, and you'll be able to expand on your knowledge a little bit. As Carla said, I am Kathy MacNeill. I am a registered nurse and a certified diabetes care and education specialist. I'm also board certified in advanced diabetes management. So that, and, a couple dollars and I get a cup of coffee like everybody else. But that is what you're seeing in front of you today. So in case you just wondered what they were. So with diabetes, what happens when we eat food? When we eat food, most food is turned into glucose, which is sugar. Okay, glucose and sugar, I will use the terms interchangeably. But when we eat, our food is sent to the stomach, turned to sugar, sent into the bloodstream where it's used for our energy. It is our main source of energy, so we have to have glucose. In normal metabolism, our cells basically have receptors on the outside, and they're like little doors. And those doors stay shut unless insulin comes along and unlocks them. So when the glucose gets to the bloodstream, it sits there until insulin unlocks the receptors so that the glucose can get in the cell. All our cells need glucose for energy. They want glucose for energy, and so they need this insulin to let the glucose in. With type 2 and type 1 diabetes, they're just a little bit different. Type 1 diabetes, the body essentially is making no insulin. And if they have no insulin, there's nothing that can open those cell receptors, so the glucose sits in the bloodstream and never gets in the cell. With type 2 diabetes, a little bit different. The body still makes insulin, but either it doesn't make enough insulin, we can't use the insulin it's making because we're resistant to it, or some other factor that's preventing all of that insulin. Maybe there's just not enough. Maybe it's, unusable, but something's causing that insulin to not be able to open those receptor doors. So that's what happens with the two types of diabetes. Now, why is it important that we talk about diabetes? Well, it's National Diabetes Month, number one. And number two, diabetes affects a lot of people. The current facts from the Diabetes Fact Sheet in 2023 show that nearly 38.4 million people in the United States have diabetes. 8.7 million people with diabetes are undiagnosed. That's 11.6% of the U.S. population that has diabetes. 1.5 million Americans are diagnosed every year. Basically, that comes down to every 17 seconds, someone is diagnosed with diabetes, right? Also in 2023, 97.6 million adult Americans have prediabetes, which is 38% of the U.S. population. Now, we're going to dig into the types of diabetes, including prediabetes, in a little bit, but I just wanted to show you kind of the impact of why we need to talk about this. Diabetes, of course, is the leading cause of new blindness among adults, the leading cause of kidney failure, and the leading cause of non-traumatic lower limb amputations. Diabetes will increase the risk of heart attack and stroke 2 to 4 times. It's huge. It's the 8th leading cause of death. And mortality rates are 2 to 4 times greater for people with diabetes than people without diabetes of the same age. So that's quite a bit of burden, but there's more to it than that. The total direct and indirect cost of diagnosed diabetes is $413 billion per year. $307 billion is direct medical costs. That's what has to be paid out to take care of these people. $106 billion is in reduced productivity, when people have to miss work or they can't function because the diabetes is acting up, or they have a complication, or they have something that has to be resolved. Even if it's just acute complication, high blood sugar or low blood sugar, something reduces productivity, and that's affecting $106 billion a year in the United States. Total diabetes-related costs are more when you add in gestational diabetes, prediabetes, and undiagnosed diabetes. It's estimated that 1 in 5 healthcare dollars is spent caring for someone with diagnosed diabetes. That's a lot of money. 1 in 10 healthcare dollars is attributed directly to diabetes. So people with diagnosed diabetes have more than twice the average medical costs. There's actually a television commercial that's out there right now that talks about how much it could cost to take care of diabetes in the United States. And these people are going, I don't know what's worse, having diabetes or paying for diabetes. Whatever. It's an expensive thing. And there are a lot of things we can do about it, but it affects a lot of people. So what diabetes is a collection of things. It's the inability of the body to use that glucose or the inability of the body to absorb that glucose into those cells. So why do people not know they have diabetes with all those that are undiagnosed? Why don't they know they have diabetes? These are the symptoms of diabetes or the symptoms of high blood sugar. You have increased thirst, increased urination, blurry vision, feeling tired, slow healing of cuts or wounds, more frequent infections, weight loss, or nausea and vomiting. So with all of these symptoms, why don't we know? Well, I'll tell you why. I'm glad you asked me. We don't know because we can pass a lot of these symptoms off as something else. And until you get to some of the more serious symptoms, people really have no idea and they don't pay attention. For example, with the exception of maybe the last 2 days, we live in Florida and it's hot in Florida. Well, when it's hot, what happens? People start drinking more water. So they don't pay attention to the fact that they're more thirsty. They just think it's hot outside. When you start drinking more water, what happens next? You start going to the bathroom more. So there's the increased urination. Blurry vision. Now, most people over the age of 40, 45 can tell you vision starts to change. Well, I don't know. I got my first pair of glasses when I was 6 years old. And so when my vision gets blurry, I don't think it might be anything else. I think it's time to get my prescription changed. Feeling tired. I love this one because I hear this from people all the time. Well, I'm not as young as I used to be. Well, you know what? I'm not as young as I used to be either. However, we're not supposed to be dragging around tired all the time. But when you put all these symptoms together, including the slow healing of cuts or wounds, maybe more frequent infections, weight loss, which usually comes when the type 1s are diagnosed, or nausea and vomiting, all of these things together say something's wrong, and that points to high blood sugar. So we've got a couple main types of diabetes to talk about. Type 1 diabetes, type 1.5 diabetes, and type 2. Many of you may not have heard of type 1.5, but I like to mention it because it's out there and you need to understand what the term is. So type 1 diabetes used to be called juvenile diabetes. It used to be called insulin-dependent diabetes, but those terms are so blurred at this point, we simply call it type 1. Type 1 diabetes is an autoimmune diabetes, which means the body turns on the cells that make insulin. Because it attacks the cells that make insulin, these people cannot make insulin on their own, so it makes little to no insulin. Type 1 diabetes used to be diagnosed in people under 30, but now we're seeing it diagnosed later in life. So I can have somebody 9, 10, 11, 12 years old come to me diagnosed with diabetes, and I don't necessarily know which type it is unless they do some testing on them. Type 1.5 diabetes is basically type 1 diabetes that's diagnosed later in life. It's called latent autoimmune diabetes in adults. That means it's this autoimmune diabetes, but it can show up much later in life, 40, 50, 60 years old even. So that's why they call it type 1.5. It's still the autoimmune diabetes. The body attacks cells that make insulin, but it's showing up later in life. Type 2 diabetes is a condition of insulin resistance. So where type 1 diabetes is insulin deficiency because the body doesn't make it, type 2 is insulin resistant. That means the body can't use their insulin well. They're still making insulin, but either they're not making enough insulin or the cells are very resistant and won't open to that insulin. So it takes more and more to push those receptors open. Something is going on, or it could also be that the body is releasing extra glucose. When our bodies think they're starving and they can't access that glucose that's sitting in the bloodstream, the liver will release stored glucose to try and feed the body because those cells want that glucose. They don't know that there's glucose on the other side of that cell membrane, so they trigger this thing to try and get more glucose. Basically, that glucose is sitting there in the bloodstream, can't get in the cells. And that's why we call it high blood sugar. We don't call it high cell sugar. We call it high blood sugar because that sugar is in the bloodstream where it's not supposed to be and not getting in the cells. All right. So type 1 diabetes. Let's delve into this just a little bit more. 1 in 20 people with diabetes have type 1. So it's not as common as people think. Most people are diagnosed under the age of 20, but again, we can see later in life where some of this comes on. It gets to the point where the body can no longer make insulin. Very often when they're diagnosed, we find out they go through what's called a honeymoon period where the body tries really, really hard to make insulin again, really hard to manage this. But after a while, there is total destruction of those beta cells and the body's not going to make insulin. So insulin is always needed for treatment. There is no way to treat type 1 diabetes without insulin. Signs, usually when somebody's diagnosed with type 1 diabetes, there's a lot of weight loss. Why? Because essentially, if the cells can't use that glucose, they're starving to death. And when they're starving to death, the body starts to break apart fat for energy, trying anything it can do to try and fuel itself. And so a lot of weight loss very often happens with type 1. There's going to be a loss of energy. They have no sugar. They have no supply. They have nothing to live on. Increased thirst, frequent urination. The increased thirst comes because the body's trying to, if you go back to your days of chemistry, we talk about osmosis and diffusion. Well, the body's trying to settle that amount of sugar. It's trying to regulate how much sugar is in the cell and how much sugar is out of the cell. So we start trying to get rid of the sugar through the urine, and that leads us to be thirsty because it starts with this dehydration phase. It can lead to something called diabetic ketoacidosis, which is an emergency condition. It basically can lead to a high diabetes coma. Blood sugars are very high, body gets very dehydrated, and the entire acid-base balance of the body changes. So that's what happens with diabetic ketoacidosis. So managing type 1 diabetes, the basic premises to manage this is blood glucose monitoring. Everyone has to keep an eye on where their blood sugars are. No ifs, ands, or buts. Education. You can't manage anything if you don't know what it is, how it works, and what you're supposed to do about it. So education is paramount. Healthy food choices. We obviously know people have to eat healthy. Everybody knows that diabetes and food goes together. So we need to know healthy food choices. Physical activity, very important in managing type 1 diabetes because exercise lowers blood sugar. It's kind of a neat premise, but exercise really can help pull that sugar into the cells and out of the blood sugar where it's sitting. And obviously insulin. The type 1s have to have insulin. Now here's an interesting picture that I like to show. The discovery of insulin in 1921 changed type 1 from a death sentence to just a chronic disease. And this picture shows a 7-year-old before insulin treatment, and you can see how small he was, how emaciated he was, and 3 months after insulin therapy, he was finally getting back up to his normal size because his body was finally using that glucose. Essentially, he was finally eating. Even though they were trying to put things in his mouth, he was finally able to absorb that glucose that he needed. Oops, I'm sorry. Type 2 diabetes. Whole different thing now. With type 2 diabetes, that's a majority of the people with diabetes. 95% of the people with diabetes have type 2 diabetes. Most of the people are over 40 when diagnosed, but it's becoming more and more and more common now in younger people and teens. Type 2 is more likely in people who are overweight, who are of high-risk race. The African Americans, Asian Americans, Hispanic Americans, and the Pacific Islanders are more at risk for type 2 diabetes. People that have a family history of diabetes are more at risk. The sad thing about type 2 diabetes is that I don't feel, and this is, opinions, what they say about opinions, but it never should have happened in the pediatric population. We're seeing kids as young as 8 and 9 years old being diagnosed with type 2 diabetes. The youngest one on record that I know of was a 3-year-old, but it was a 30-pound 3-year-old. Okay, this child was way too big for its age. And so a lot of this is happening because of our change in lifestyle. years ago, we didn't have the same problems we have now, but now we can look at things like fast food, convenience food, processed foods, things we didn't have before. And then you combine that with television, computers, Nintendo, and the fact that PE is being taken out of the schools and it's definitely not being used as much as it used to be. Now we have kids who are sedentary. They're not active. They're not eating as healthy and they're getting heavy. And that's what's causing this shift in type 2 diabetes in the pediatric population. So some symptoms of type 2 diabetes, again, very much the same as type 1. They're usually very subtle or no symptoms very early on. The body learns to live with glucose as it gets a little bit higher, a little bit higher, a little bit higher. The body learns to tolerate it. And until it's really, really high, a lot of these people don't have any symptoms. Symptoms like increased thirst, urination, feeling tired, blurry vision. Blurry vision is very common in the diagnosis of type 2 diabetes because there's a shift in the fluid in the body, and so our vision goes out of check. When the blood sugars come back down, the vision can actually return. And more frequent infections. 1 in 4 people with type 2 aren't aware they have it because, again, we can take these symptoms and we can pass them off as something else. So hyperglycemia or high blood sugar over long-term process can cause serious problems. Chronic complications of diabetes can include things like blindness, kidney disease, nerve damage, amputations, heart attacks, and strokes. These are major things that we don't want to happen, and these are chronic complications. So just to touch on a little more about what I said with the pediatric population, this does show adult trend. Oops, I'm sorry, I skipped a slide. Forgive me. I get ahead of myself. So treatment for type 2 diabetes may change, but you always need to have education, healthy eating, blood glucose monitoring, physical activity. The same things we talked about with type 1. The big difference is with type 2 diabetes, it can be treated with diet and exercise, but it can also be treated with other medications, the pills, the injectables that are not insulin, and then insulin, or any combination of those. It's really about getting these people in control and keeping them in control. That's the key to taking care of diabetes in a healthy manner. So, risk factors for type 2 diabetes: being overweight, sedentary lifestyle, family history. A history of gestational diabetes puts a woman at risk for type 2 diabetes. Age. Unfortunately, if we get older, we're more at risk for type 2 diabetes. I have often said in my classes that if you live long enough, you'll get type 2 diabetes, because I had a woman who was diagnosed at 92. She was in great shape. And she said, "Why am I being diagnosed now?" And I said, "Because your pancreas is 92 and it doesn't know it's not supposed to be tired." So if we live long enough, we can get type 2 diabetes. And again, those high-risk races that we talked about. So how do we lower our risk of complications? Well, we have to get ourselves in control. And that means we have to get this A1C less than 7. We have to get our blood pressure in control. Right now, current guidelines say less than 130/80. Our cholesterol, we need our bad cholesterol less than 100. Optimum for people with diabetes is less than 70. We need people not to smoke. We need people to be more active. We need people to make healthy food choices, take care of themselves, especially their feet, and get their recommended screenings for early treatment and complications. These are things that should be done with everyone. All right. So with our treatment of type 2 diabetes, we want to expand the ABCs. They always talked about the ABCs, and that would be the A1C, blood pressure, and cholesterol. But we want to look at some other things, okay? We want to look at the D for diabetes education. Very, very important. Again, you can't manage something you don't know anything about. E for eye examinations, and I'm going to touch on that in a second because that's really important. And it is National Diabetic Eye Disease Awareness Month. So there you have it. Foot examinations, really important because our neuropathy can tend to start in the feet. So keeping those feet examined is very, very important. Glucose monitoring, health maintenance, and other indications for specialty care, like, do I need to see a specialist? Do I need to go to a new provider? All right. So this is why we talk about obesity, because if you look at the obesity trends in the United States, they've really, really increased. We didn't have this much back in, 2000, change of the century. But this is the obesity trends, just to give you an idea. And this is the diabetes trends for the same year. So I put them side by side so you can see them, because you can see that overlap. With obesity and high weight, we have a much, much, much greater risk of diabetes. All right, so prediabetes. Mentioned it before, want to mention it just a little bit again. Prediabetes is a condition where the blood sugars are higher than they're supposed to be, but not high enough to diagnose. 96 million people have prediabetes, with 24 million people over 65. That's a lot of people. The blood glucose levels are higher than normal. And a lot of people don't know they have prediabetes. Unless the doctors are screening for it and unless they're checking annual labs, people don't know they have prediabetes. Just to give you a difference of where diabetes is diagnosed and what's prediabetes and what's normal, I have a slide here that looks at the A1C, a fasting plasma glucose, and an oral glucose tolerance test. Mostly people will look at the A1C or fasting plasma. We diagnose diabetes over 6.5 with the A1C. Prediabetes is between 5.7 and that 6.4, or less than 6.5, and less than 5.7 is normal. With fasting blood sugars, less than 100 is normal, 100 to 126 is, or less than 126 is prediabetes, and we diagnose diabetes at 126. Now, prediabetes, a lot of people think, well, if I have prediabetes, I'm destined to have diabetes. Not necessarily. Prediabetes can be stopped in the prediabetes stage, and you don't necessarily have to be diagnosed with type 2 diabetes. So some of the things that we have people do, and we have classes here at Florida Healthcare for prediabetes, but 5 to 7% of your body weight should be reduced. Okay, just 10 to 14 pounds for a 200-pound person in a 6-month period makes a huge difference. Regular physical activity with at least 150 minutes a week. That's 30 minutes most days of some kind of moderate activity, and healthy food choices. Now, is it really possible to prevent the diagnosis of diabetes? I like to think so, because I have had prediabetes for 22 and a half years now, and I still have not converted to diabetes. So yes, we can prevent this thing from happening. We can reduce the risk of it developing. We can reduce the risk of developing complications through blood glucose control, blood pressure control, cholesterol, regular visits to healthcare providers, and early detection of complications. So complications are not inevitable, and there's a way to stop most of them. If we can modify some of these things here in front of us, those are modifiable risk factors. If we can turn those things around, we can prevent a lot of this. One of the complications that we were asked to talk about right now is diabetic retinopathy. That's the disease of the retina that's caused by long-term poorly controlled diabetes. Now, the key word there is poorly controlled. It is one of the leading causes of blindness. Development severity of retinal disease is directly correlated to the control of blood sugar. If your blood sugars are out of control for a long period of time, you're more likely to develop diabetes eye disease. If you keep your diabetes in control, you can reduce the risk of eye disease by 76%. That's huge. Has no impact on vision in the early stages, so people won't know they have this. That's why annual eye exams are critical. Somebody has to look at the back of the eye at the retina to find out if there's any disease. Treatments are more effective in early stages before the vision is severely impacted. Now this, we were sent by Dr. Geis, kind of a very cool thing, because it shows what a normal retina looks like, and it shows what a retina looks like in somebody with diabetes. And there's a very big difference. You can see all these little micro aneurysms that are there, which are these little balloons that are popping up because there's little blockages. It's trying to build a lot of extra circulation in there. So it's got all these new vessels that are trying to be formed. And all of those things get very, very tangled. And literally that can pull the whole retina off the back of the eye. With very severe eye disease, you get scarring and disorganization of that retina. This particular patient is blind. There is no more circulation. There's no way that they can see anymore. And the control of blood sugar in annual eye exams could have prevented this. So we are all about prevention. Most of the diabetes costs are due to end-stage complications. Investment into resources into early diagnosis, patient education, prevention, and treatments pays off in longer lives, increased productivity, and reduced costs over the long term. So if you want any more information, please call the 1-800-DIABETES, which is the American Diabetes Association. I apologize. The 800-533-CURE now goes to Breakthrough Type 1 Diabetes. They used to be called Juvenile Diabetes Research Foundation, but they have recently rebranded. And Breakthrough Type 1 is the new name of it. And if you need their website, I can get that for you. We also have classes in self-management education, healthy heart, our weight loss classes, pre-diabetes. Oh, we have healthy heart twice. Kidney classes. We have classes in anything that we can help to turn this around or prevent this from happening. We do group classes. We also do individual appointments. So, and we do video appointments. So we try and meet the patients as best we can.
Do we have any questions for Kathy?
So I was wondering, we in our case management department, we deal with a lot of members who have diabetes. So is there any specific, other than the hemoglobin A1Cs, any specific labs we should be looking for? And if they're not done, that we can ask those from the physician?
Right. So interesting that you should ask this question this time of year. Starting in October, our department looks at the annual diabetes exams, specifically the A1C, and we reach out to members who have not had diabetes labs done in the past year. We look at the A1C, we look at a fasting glucose, which is a chemistry panel or a CMP. We look at a CBC, we look at the lipid panels because we know cholesterol has to be in check. And then we also do a urine microalbumin to see if the kidneys are spilling protein because that's one of the early signs of kidney disease. So those are the 5 that we send in with our panel when we do this project at the end of the year.
Thank you.
You're welcome.
And can patients self-refer, or do we need to put a referral in for them?
Okay, so great question. Patients anybody can self-refer to the class for our group classes for diabetes. If they want to meet with the dietitian individually, which we highly recommend, we do need a referral for that. So if someone self-refers for the class, we will get them scheduled and then we'll reach out to their physician to try and get that medical nutrition therapy referral. The medical nutrition therapy referral allows them to have a one-on-one with the dietitian and get a meal plan that is designed specifically for them. So we need that to bill the dietitians, but we don't need it for the classes.
Okay, thank you. I appreciate that.
Sure, you're welcome.
Well, thank you everybody for joining us this afternoon. I hope you enjoy the rest of your day.
Thank you, everyone.